Thanks very much again for the opportunity. We keep talking about lithiasis of the urinary tract. We know, of course, the prevalence, which is beyond that, between 1 and 13%, with a noticeable increase in some areas of developed countries. And the fact that we keep talking about the disease and trying to find solutions, stuff like that, it proves that it is a severe disease because it is linked to chronic kidney disease. So of course we have many types of stones as far as composition is concerned, with calcium oxalate being the commonest. Now with regards to treatment, it is based on various parameters. First of all, on the parts of the stone, the size, the volume, shape, or whatever of all these, the hardness of the stone, and also on the parts of the patient, in particular on the anatomy, depends on the anatomy of the pelvic-calyceal system. So the treatment should be individualized, and we have these three options for stone disintegration. Now, coming to the shockwave lithotripsy, well, this was if I may say, a revolution back in the 80s, because it shifted treatment from the invasive open surgery, heavy surgeries, surgical procedures and things like that to a minimally invasive technique. So it was a revolution at that time. Of course, for the during time, this enthusiasm initially has subsided, but still shockwave lithotripsy is recommended for stones, renal stones less than 2 centimeters, and also for ureteric stones less than 1 centimeter according to the guidelines. Now the efficacy is related to the shockwave rate, whether we have an ideal acoustic coupling, the power ramping, and of course the control of pain, because if the patient feels pain, he moves a lot, and then focusing the target is very difficult. The stone is very difficult. Generally speaking, shockwave lithotripsy is let's say the least invasive of all three procedures like this. It is considered to have fewer overall complications compared to RIRS and PCNL. And these are the complications. With regard to bleeding, which is my topic, we have a substantial, let's say, number of patients with macroscopic hematuria at the level of 17%, which is not, in most of the cases, a problem. Usually it subsides after a couple of days. The patient goes home, takes lots of fluids and bed rest and things like that, and then the hematuria resolves, and so it's not really a problem. On the other hand, renal hematoma, either in the form of asymptomatic or symptomatic, is at the level of 1% or less. This could be a problem in some instances. And the formation of such a hematoma is a complex interaction between the shockwave physics and the tissue biomechanics. And also is dependent upon the energy that we deliver to the stone, the shockwave characteristics and the factors from the patient. Now the incidence and the way we discover these hematomas varies significantly, because it primarily depends on the detection method that we use. For instance, if we use the newer techniques like CT scans and MRI scans, will result in a higher radiographic incidence, whereas if we use the ultrasound scan, which has a lower sensitivity, the incidence is less than 1%, as shown here. Now, this was a post hoc analysis of 2 randomized controlled trials, which it was published some years ago. It included nearly more than 500 patients. About half of them were hypertensive, were taking drugs for hypertension, and they had relatively hard stones. So what the authors did, was to perform a CT scan 48 hours after the procedure, and they found that in 1/3, in 31 of the patients, there was a hematoma. But of all these hematomas, only 1.7% patients had symptoms. So we expect to have an hematoma in a substantial number of patients after the shockwave lithotripsy. And the risk factors that were reported for this was, of course, the energy that was delivered to the stone, higher energy, more complications, more hematomas. Of course, the stone density, either the higher mean or high maximum stone density, and interestingly, the location of the stone to the lower pole. On the other hand, when they used the stepwise ramping, this was protective. The hematomas were reduced by nearly half. So these are the results of this post hoc analysis, and we can see here the statistical significance of this study. Hypertension, which is considered a risk factor, but many authors was not really a risk factor in this particular study. But usually, potential risk factors for bleeding after the shockwave lithotripsy is obesity. Obesity in obese patients, the efficacy of shockwave lithotripsy is less than expected because there's a larger distance between the energy source and the stone. However, due to the metabolic syndrome, we have an endothelial dysfunction and altered coagulation, and also we have a chronic inflammation state which predisposes to hemorrhage. Other potential risk factors, the older age, because of the stiffness and the fragility of the vessels. Hypertension is recognizable as a risk factor as well. And there's much debate whether the antithrombotic medication predisposes to hematoma formation if the patient ceases, stops the medication prior to the procedure, either 3 or 7 days. We had the last speaker to comment on that. So it has to be a case-by-case evaluation beforehand. And we have to discuss with the patient that there is a potential, there's a risk of having hematoma afterwards because the patient really expects to go home after a couple of hours after the procedure. It regards it as a very easy procedure, so any complication really is of concern on the part of the patient. And we can see here the risk factors. So what about prevention? What do we have to do to prevent bleeding during the extracorporeal shockwave lithotripsy? First of all, is to use the stepwise voltage ramping, which reduces the risk by 62%. We have to optimize the shock waves. The maximum is 90 shocks per minute. We not need to exceed that. It's not safe to exceed that. We have to carry out a meticulous pre-procedure workup to check the coagulation status of the patient, send off an INR, APTT, urine cultures, which should be negative. And also, like I said previously, to stop the antithrombotics, antiplatelet drugs. Now, coming to the second of the procedures, which is ureterolithotripsy or flexible ureterolithotripsy, it is, as we discussed earlier, an operation with increased popularity. Its indications have broadened, and this is mainly due to the advances in technology and equipment. We have better scopes, better laser devices, and hence this procedure may be used in more complex cases and in higher risk patients. Still, it is a therapeutic options for renal stones less than 2 centimeters. According to the Crow's global study, the stone-free rate is about 86%, and the overall complication rate is about 7%. With regard to bleeding, we had 1.41% chance of intraoperative bleeding, and also after the operation, the bleeding can occur in about 0.45% of patients. So it's not very common, but it is a complication we have to bear in mind. For semi-rigid ureterolithotripsy, there was a very nice systematic review published back in 2017. It was a meta-analysis of 7 studies, including nearly 9,000 patients. And they found that the perirenal hematoma following ureterolithotripsy was below 0.5%, with the mean stone size of the patients about 1.7 centimeters. And there were predisposing factors like severe hydronephrosis was recognized as a factor, hypertension was one of them, prolonged operation, preoperative UTI, and then the thin renal cortex. Usually the hematoma is treated conservatively. In this particular meta-analysis, 55% of cases were treated conservatively. There were 1/4 percutaneous drainage of hematoma, and 17% of patients required a JJ stent or another form of intervention. We had the chance to review the literature, to dig out the literature in our department. We had 4 perirenal hematomas over a 10-year period. Interestingly, there were no predisposing factors in this series. Only one patient had the prolonged operation, prolonged between quotation marks, 90 minutes. So 3 of them were treated conservatively, but one had to undergo arterial embolization twice, which led to loss of renal function on a DMSA carried out 4 months afterwards. And we can see here the resolution of one of the hematomas. Now, as prevention measures for the ureteroscopy, ureterolithotripsy, is first of all the effective preoperative treatment of UTIs, control of hypertension. We have to monitor the guide wire. Everything has to be carried out under a fluoroscopy. We have to maintain and constantly decrease intralesional pressure, preferably use gravity infusion if at all possible, and then it is advisable to have a JJ stent inserted after the operation. Now, during the flexible URS, the source of hemorrhage is practically the same. We have bleeding from manipulation of the guide wire, of the scope, of the stone basket. Also, we have sometimes trauma to the ureter and bleeding from the session of the access sheath. We're not sure whether the increased intralesional pressure may lead to bleeding. What it does is leads to intralesional backflow and follicular rupture, which predisposes to urinoma. We're not sure about the effect on the bleeding. And also the laser may cause bleeding if you contact the laser fiber with the mucosa. Now, there's a flexo registry which included about more than 6,500 patients with a mean stone size of 1 centimeter. The probability of bleeding during the operation without requirement for blood transfusion about 5%, as shown here, but very, very less when transfusion was required. In this flexo registry, 80% of patients had at least one postoperative complication, and postoperatively, the risk of bleeding requiring blood transfusion was about 5.5%. So it's not something that it is something we have to bear in mind. With regard to intralesional pressure, like I previously mentioned, it is linked to sepsis with the mechanism that is not entirely understood, but we don't exactly have sufficient data to support any correlation with formation of hematoma or other forms of hemorrhage. Of course, it increases during surgery, we know that. The question is whether there are any safe levels. It was mentioned yesterday that normal intralesional pressure is below 15 millimeters of mercury. Above that, backflow either to the tubules or to the veins, the veins ensues. This follicular rupture is something that we have to be considered about, because after 70 millimeters of mercury, we have potential extravasation, potential hematoma outside the kidney. So, on the other hand, we have some measures to drop the intralesional pressure. First of all, this is the axis of the ureteric insertion of the ureteric access sheath, which increases the outflow. We have active suction to drop the pressure and prevent backflow again. We have the fans. We have lots of discussions this morning about this. which is better, let's say, if I may use this word, than the conventional access sheath. And it has been also compared to mini PCNL in a study and showed reduced bleeding. Now, prevention measures for this, for the flexible uteroscopy to avoid bleeding is, again, effective preoperative treatment of UTIs, control of concomitant diseases, intraoperative monitoring of the guide wire tip, cautious manipulation of the scope, maintenance of the constant decrease in intralesional pressure by using either the sheath or fans. So these are prevention measures that usually drops to very low levels the probability of having postoperative or intraoperative bleeding. And finally, the most invasive, let's say, of these three treatment options, the PCNL, it still is a starter method for smashing large stones more than 2 centimeters. Of course, we have variations with regard to the position of the patient, the imaging method, the diameter of the tract, the dilatation method, and so on and so forth. But we have, generally speaking, bleeding and postoperative fever are the commonest of the complications reported. We can see here the fever is expected to 10% or 11%, and bleeding requiring transfusion in 7%. There was a review by Sides et al. Which was published some years ago, but the authors tried to correlate complications with the categorized complications according to the Clavin classification, and we can see here that overall 77% of patients did not really have any complication. And of all the others, 11% had a grade 1, which means that either a fever or something that did not require any intervention. So this one in total is 88%. Of the patients having complication, 50% of them did not have any, did have Clavin 1 complication, which is in accordance with the results of the CROW study. Again, 54% of complication which were deemed mild, Clavin 1. And now, bleeding which requires transfusion is related to several factors. Bleeding can occur in a more, if we have larger tract size, multiple punctures, perforation of the renal pelvis. It is advisable not to puncture the lower pole calyx, or calyx anyway, instead of the renal pelvis. Sacrum calculi, supracostal puncture, because you have to, most probably you may cause injury to the arteries. Prolonged operation, of course, and of course, when the preoperative hemoglobin levels are too low and the blood loss is excessive, you have to transfuse the patient. Bleeding during and after PCNL mostly occurs due to the vascular injury during the dilatation of the tract, and it can be either venous, which is really not a problem during the operation, can be acute because a segmental artery has been traumatized, or delayed, which may indicate arteriovenous fistula or a pseudoaneurysm. Fistulae are characterized by persistent hematuria and a slow drop in hemoglobin levels. The only treatment for that is the arterial embolization, as we all appreciate that. And also, we expect substantial incidence of perirenal hematomas because you have penetrated the kidney. In 1/3 of patients, we have some form of perirenal hematoma with only 1% requiring embolization. And we can see here the prevention measures, proper coagulation status, drainage in some instances for the hematomas, usually it subsides, and also tambonate for venous hemorrhage, but only embolization if an artery has been traumatized. So in conclusion, the hemorrhage during endourological procedures may sometimes be a severe problem. Prevention should include knowledge of the risk factors that the patient may have, and a thorough pre-procedure evaluation and cessation of anticoagulants, preferably in consultation with the prescribing physician, cardiologist, for instance. The intraoperative manipulations should be careful and lege artis, as the Latins used to say. And finally, a thorough postoperative follow-up is the key for a best result. Thank you for your attention.